Welcome to ThePrint. As COVID-19 cases see a dramatic increase across the country, we bring you this new show called Virus Decode, where the Print team and health experts, all of us get together to decode the causes, impact, and preparedness in India for you. Today, we have a fantastic panel with us for you. We have Dr. Bhramar Mukherjee, biostatistician, epidemiologist, and professor at the University of Michigan's School of Public Health. We have Dr. Ambarish Satwik with us, who's a vascular surgeon at Delhi's Sir Gangaram Hospital. And we have with us our in-house expert and health editor, Abantika Ghosh. All of us will answer all your questions and decode this virus for you in the next 30 to 40 minutes. So my request to all our viewers is to send in all your questions to us, and I'll take them up one by one for all of you. As for our panelists, a big thank you to all of you for taking out the time today and joining us. My first question is for Dr. Mukherjee. Now, to begin with, I'd like to start with a very basic question. Where is the pandemic headed? And if you look at the numbers, what can we expect in the next few days?
I wish this could be classified as a basic question. So I do think that we are expecting what you have been seeing for the last few days, that there would be a surge in terms of infections. And I think that that is expected, and we should not panic about that, because we have seen that in that trajectory in the United States, in the United Kingdom, in South Africa. We should really track in terms of severity of cases. But at the same time, I think that what we saw in the US, that even directly COVID-related hospitalizations were limited, particularly in the vaccinated people. We saw a huge crisis, a healthcare crisis exploding because just the sheer volume and number. And so I'm bracing myself for that possibility. What our projections show is that we are going to really skyrocket in terms of infections, and it would be very difficult to track because the tests are not probably going to scale up as fast. But we really need to track the hospitalization and ICU occupancy, particularly hospitalization for this variant.
Dr. Satwik, here I'd like to come to you and just put up this question for you. Something that everybody's talking about right now is the booster shots. Could you tell us a little bit about the timing of the boosters, and also what is the evidence on using the same vaccine as the precaution dose? If you could tell us a little bit about that.
Right. Thank you for having me on the show. First of all, I'm not sure about the semantic wisdom of the word precautionary. I don't understand what precautionary dose means unless people aren't abundantly confident that the dose is not going to boost enough, which is why it's not called a booster. Because otherwise, the third dose for someone who's primed should be a booster. And there is this kind of almost like a nazar charm kind of Nimbu Mirchi sentiment attached to precautionary as opposed to real science. So, unfortunately, out of the vaccines that are available to us, there isn't any convincing evidence that the third dose, if used following 2 priming doses of the same vaccine, is going to boost the immune response to any great extent. And perhaps the paper that one could refer to is the Cough Boost study data. This was a study that was carried out in the UK, and it was recently published in the Lancet. And one arm of the study is of particular relevance to us because it used the Oxford AstraZeneca vaccine, 2 doses in individuals who had been primed with 2 doses. They tried a variety of vaccines as a boosting dose, and they observed immunogenicity in this arm of the study. When these individuals who had been primed with 2 doses of the Oxford AstraZeneca vaccine, which is Covishield in India, and 90% of the eligible population has been vaccinated in India with Covishield, when they gave them a 3rd dose of the same vaccine, the Oxford AstraZeneca vaccine, they found that there was a very, very modest increase in the number of neutralizing antibodies, the antibody response. The geometric mean ratio rose by roughly about 3.25. When they used another vaccine, which is called Novavax, which has recently received emergency use authorization as on 28th December, and is being manufactured by the Serum Institute as Covavax. They saw that the geometric mean ratio increased by 8-fold. All right. The maximum increase was seen by the mRNA vaccines, almost by 24 times. But even when you compare Covishield as a booster, which increases by 3.25 times, as opposed to Covavax, which increases it by roughly 8 times. And even half dose of Covavax increased it more than what Covishield as a booster would achieve. Clearly, it indicates that the choice of booster in Indians should be Covavax, because let's face it, we don't have the money, the resources, the personnel, and the energy to keep boosting our population. We have to do it once and you have to get it right. So why use a subpar vaccine as a booster? So that's the data on those who've been primed with Covishield. There's absolutely no data for individuals who've been primed on Covaxin receiving a third dose of Covaxin. So to me, this policy programmatically doesn't make too much sense.
Okay, and Abantika, just to get to you for a minute here, you also have been tracking the pandemic since it began. Could you tell us a little bit about the timing of the booster shots as well as the current rate of vaccinations?
So vaccinations are, currently the numbers, there was a point of time when the numbers had gone quite high. Those numbers are not there. We're currently doing about 85 lakh max per day. But we also have to understand that 90% of Indians have got the first dose, and 90% of Indians who are vaccinated have actually got Covishield, whose second dose interval is it's 12 to 16 weeks. That's a very big interval. So it's not necessarily the pace slowing down so much. Maybe also the numbers have gone up slightly. So when I say 85 lakh, I'm taking into account the 15 to 18 vaccinations. So the numbers have gone up a little bit since then. But I think the slowing down is also kind of inevitable because there's a waiting period for the second dose, and people will have to wait out their thing before they can get the second dose. Covaxin, just about 8 to 10% of Indians have got Covaxin, so the 28-day thing interval isn't significant. The interval that we should be looking at really is 12 to 16 weeks. So I think that's why the slowing down, basically.
Dr. Mukherjee, a question for you here. Now, what about tests? Last year, WHO motto on COVID was test, test, test. Do you think that applies to this wave as well? Or is it a sound logic to let the virus wash through the population, as Boris Johnson had once famously said?
So I do think that you probably can guess what I'm going to respond to this question as, because I've tweeted quite a bit about it. So I do think that the testing, you have to be very clear about what is the goal of testing. Is it for clinical diagnosis or it's for population surveillance? I also need to distinguish between home tests, home self-care tests, and also RT-PCR. So I personally have been following a regime, and that's because I'm in close proximity with my parents who are in their 80s, and I have been traveling all across the continent to get tested every day with a home test. And that's not possible for everybody, but I do think that this rapid antigen home test can really help us, if we could make them affordable and really flood them, to keep things open. Because, if before boarding a flight, if you take a home test and 2 hours before taking the flight or 5 hours before taking the flight, and you find that you are contagious or you're infected and you're asymptomatic, that could really prevent a super spreader event down the road, or you have mild symptoms. So one person or a group, a family not boarding a plane has downstream consequences here. So I do think that that type of self-testing as a prevention strategy to mitigate the spread is a very useful strategy. And the Michael Mina Lab has been writing a lot about that. And the US government is also being criticized for not making them affordable. So in the early days of the pandemic, actually, our county offices were sending us boxes of free home tests so that we could test ourselves, because the asymptomatic spread was a big concern. So with Omicron ripping through the population, And we have to prioritize, right? Prioritize in terms of who gets to go for the RT-PCR, because I think soon you'll see that there is a bottleneck in terms of how much testing can we do. So for, it has to be context dependent. And if you have symptoms and mild symptoms, and if you are in a family where someone has tested positive, does everybody else need to get tested positive and get to have a confirmatory test? I don't think so. I do think that self-tests should become more common. And my only reason for saying that I want to do a self-test, and then if I turn out positive or I have symptoms, I want to RT-PCR, is because as a modeler, I also want data. Right, so the RT-PCR tests get reported, and I was not so sure about self-tests, but now I see that there are many tests in India where you can actually integrate that to the ICMR portal, even if you do self-test at home. So that's very promising if that becomes much more accessible and available. But I do think that, there is the purpose for test is for my behavior. If I get a concrete COVID positive test, maybe my psychological behavior is different. I want to do testing in terms of prevention because I am in proximity to the vulnerable. And that's something where I would say that I want to do regular testing. And then I want to do it at a population level, at some level, in order to track the pandemic. If we had national level hospital dashboards with hospital admissions with COVID and for COVID, decoupled into two components, and if we did have ICU capacity nationally, not just pockets of urban metros, then I'd say that you don't need to test. But without knowing anything, are we going to assume that the entire India is on fire at the same time? How is the pandemic moving through geographies? So I do think that for that, some reporting and some knowledge is necessary, because you cannot create models out of nothing. If we had hospitalization data, if we had projections for hospitalization, that would be the key metric for me right now.
We have actually question. Just 1 second. Sorry to interrupt. How reliable are home test negatives?
So I would say that, the test that I am using has a specificity of 99% and has a sensitivity of 98%, right? So sensitivity of 98% and with repeated tests, right? So if you isolate, if you have symptoms, if you have isolate tests, if you isolate yourself, and then you have 2 negative tests consecutively over a period of 2-3 days, I will feel fairly confident that you are not contagious.
Actually, this also answers a viewer question. Vimash Chaturvedi had asked what is the overall accuracy of antigen tests. So Vimash, here's the answer for your question. We have a question coming from Namra Patel, who's also our YouTube member. Dr. Satwik, if you could respond to this. He's asking, is Omicron milder than Delta according to sample size available? And what steps the government can take in India that doesn't lead to panic in people with growing hospitalization in the coming days due to the spread of the virus?
Yes, I'll respond to that. But if I might just add to what Professor Mukherjee said.
Of course.
The objective of the lateral flow test is to pick up infectiousness rather than an infection. All right. Well, that means that it's incredibly accurate during the peak period of infectiousness, when an individual is able to infect others. And the thing about this virus is that you turn infectious before you manifest symptoms. So it's a great test to make sure that seemingly well people don't go around infecting others. You can rely on this cheap test if you are symptomatic, if you don't have access to RT-PCR. But the primary objective of the lateral flow test or the rapid antigen test is that it's a great method of sifting through seemingly well people who might be infectious on that particular day. So a lateral flow test today would mean nothing tomorrow. In case you're meeting someone without your mask, you need to repeat that tomorrow as well. About the mildness question, so I'm going to say something that will hopefully reassure a lot of your viewers. I've been speaking to intensivists, to physicians, to pulmonologists, to radiologists for the past many days now. And in fact, in areas where Omicron has replaced Delta. Now you look at cities like Mumbai and Delhi, where prior to this wave, you found that the number of COVID positive cases in a day was really, really low. In Delhi, we had such a great run. We had less than 50 cases a day for 6 months running. And that was possibly because, we were then done with Delta, or Delta had kind of was done with us. So in those areas where Omicron is replacing Delta, physicians haven't seen a COVID pneumonia in 2 weeks or 3 weeks. All right. CT scan centers say they haven't reported COVID pneumonia. Hardly any case of COVID pneumonia has been reported. Symptoms are mild. Physicians don't even feel the need to actually ask their patients to get X-rays done or CT scans done. So this definitely indicates that this is causing a much milder disease. One doesn't know if it indeed intrinsically is a more attenuated virus, or it is so because it's meeting a more immune, a more bolstered host when it's infecting them. But this is clearly what the trends seem to be revealing. The two main reasons of morbidity and mortality that we observed in Delta, one was COVID pneumonia, and the other was the hyperimmune, the hyperinflammatory cytokine storm. Both of them are not being seen in Omicron. Largely.
If I can add a question to that, Dr. Satwik, like we were discussing before we started this program, you said you're seeing a lot of patients with COVID. So, basically, if you're making a lot of incidental findings, is that a good thing or a bad thing? The fact that people don't know they have COVID might actually mean that it is a mild infection, like you just said.
Well, in a sense, what it tells us is that this variant is kind of wantonly romping through the population. It's almost like a conflagration. So the last week of December 2021, the Office of National Statistics in the UK revealed that 1 out of 15 individuals in the city of London had been infected that week. If something is going around so much, of course, you're going to pick it up incidentally. The point I'm trying to make is that, look, the question we need to ask is Omicron causing severe respiratory disease in people it's infecting? Now, technically, any respiratory pathogen, any virus that causes a respiratory tract infection has the potential of giving you pneumonia. Okay, even the common cold virus has the potential of giving you pneumonia. The question we must ask is, are you seeing that with Omicron? Now, what happens is that if you've got a whole lot of people who are admitted or are being admitted for other reasons and are testing positive, then they will be counted as hospitalizations with COVID. Now, the distinction to be made is that, is it hospitalization due to COVID or is it hospitalization with COVID? I'll give you an example. Yesterday in our CCU and an ICU, about 3 or 4 patients who had been admitted with severe illnesses due to other factors tested positive. Now, they will be cohorted as COVID patients on ventilators. So what you will see is an increase in the number of COVID patients in ICUs, in COVID patients on ventilators. But you need to sift through this data. You need more granularity. You must ask whether the total number of patients on mechanical ventilators is increasing, or is it just that patients who were on mechanical ventilators are being cohorted now as COVID patients on mechanical ventilators? And there you will get your answer. And I would urge journalists to actually try and request hospitals to come out with these audits, because this is going to provide us with the response to the question posed to you by your viewer.
Thank you for that, Dr. Satwik. In fact, when we speak about data, I'd like to come to Dr. Mukherjee for a minute here. And now our response to an increase in cases does in a way depend on the data available, right, from the past 2 waves, as well as in real time at this point. What do you think of the quality of data from India currently?
So, there are a couple of things here. It's a packed question because data can take different forms and shapes. So first I'd go to, what did we learn from the last 2 waves that can be useful to us here? So I think there is a huge gap in terms of teasing out the effect of interventions, the public health interventions. So we have seen lots of cities, lots of municipalities rolling out different kinds of interventions in terms of mask mandates, in terms of night curfews, in terms of reducing flight services and so on. What really works? So this sifting through this world of natural experiments, we really need better articulation in terms of what has worked, because everything has a cost to public life and it disrupts public life. So I do feel that there needs to be much more work in terms of teasing apart the effect of intervention. And statistically, it's not easy because a bundle of them are rolled out at the same time. Do lockdowns work? Probably lockdowns and face coverings are the two interventions where we have solid data that they work, but then the other things in terms of restricting social gatherings, is that really feasible in India? Reducing hours for stores, is that good thing or bad thing? Reducing occupancy is probably more beneficial. So I think things needs to be more nuanced, and with Omicron, our strategy needs to change compared to Delta. So that's basically analyzing the available data. So the second part is that in terms of knowing some of the things that we want to know, and as Dr. Satwik mentioned, that we want to know hospitalization data, and we want hospitals to release the data for with COVID and for COVID at a granular level. Similarly, that goes for historic data. We still do not have disaggregated data in terms of COVID deaths in India for age and sex all over India. We have subnational data, and those data sets are very metrocentric. So this bothers me because we are extrapolating to whole of India in terms of subnational data, and the voice of the unrepresented remains unheard. So it's not just a question of data paucity, it's a question of who is being represented as well. So I do think that we need to pay attention to that. And the final thing I'd mention, that in terms of linkage of databases, it's extremely important to link the testing data with the sequencing data, with the vaccination data, so that you can say that how many breakthrough infections happened for people who received Covishield versus Covaxin. I think as consumers of vaccines, we need to know that what are the comparative effectiveness in a population, not just from clinical trials, in a real population, we need to know. So I do think that better linkages and multi-platform data cross-talking is extremely important. And the countries which have that, and US is not a great example of this because the US data system is also very disintegrated. The National Health Services, and also look at Israel because of the Clalit Health Services, because they had integrated data sources, they have been able to tell us in real time if there is an evidence of waning immunity, if the breakthrough infections are rising, if the Delta variant papers, most of the properties of the characterizing properties of the Delta variant came from UK first because of their nimble data set and analysis pipeline. So I think that we could do much better in terms of both articulating and designing our policy response, but also giving people information in real time as consumers and also receivers of the treatments and the vaccines and so on. If somebody told me that there is no need for booster given the immunity quilt of India right now with lots of past infection and vaccination, and there is no effect of waning, and here is the data over time, look at it, I'd feel much more confident in making a decision.
Of course, that makes sense.
What do you think of night curfews and weekend curfews when we have 100% seating in metro?
So that's exactly what I'm saying, that, that this is why someone has to really sit down and articulate that what interventions are actually effective. Some of the interventions are psychological effect, that people sort of shake up and then just say that something is happening. But I do not think that some of them actually have delivered on that value. So we are having a lot of unproven interventions in terms of public health interventions.
We have a viewer question from Harun Siddiqui, which I'd like to put to Dr. Satwik. Now, he's asking whether home tests can differentiate between Delta and Omicron. I know you've tweeted a lot about genome sequencing as well, so I'd like you to club your answer with that maybe and tell a little bit about that to our viewers.
So home testing with the lateral flow test cannot distinguish between the variants of SARS-CoV-2. usually you're looking for specific antigens on the lateral flow test.
Mhm.
And if I'm not mistaken, the most lateral flow tests look for the nucleocapsid antigen on the virus. Now, RT-PCR is an incredibly sensitive test, which looks for specific genes and amplifies them. The idiosyncratic thing about Omicron is that it will test, it will be picked up when RT-PCR is being done for, let's say, 2 genes, but it will not be picked up when the test is looking for the S gene. All right. So let's say you have 2 or 3 different genes that the RT-PCR test is looking for, and it's picking up 2, but it's dropping out on the S gene. That's an indirect evidence that the test has picked up Omicron. Indirect because you have to confirm this with genome sequencing. Now, there is a limited capacity for genome sequencing anywhere in the world. So you cannot start picking up every sample and subjecting it to genome sequencing. But this S gene target failure or the S gene dropout is a quick surrogate or a quick proxy to identify Omicron. And even this, because what's happened is that some of the kits that are available for the S gene kits are not commonly available in India. There's one particular kit that has been manufactured by I think Thermo Fisher, which is expensive, and I don't think laboratories can start using it because there's a cap on how much you can charge for an RT-PCR. But there are some indigenous kits which I believe were awaiting ICMR approval, which still hasn't come in to the best of my knowledge. My advice would be that now is the time to actually start sequencing severe disease. When you're seeing true severe disease, at least subject it to the S gene target failure test to find out if it is Omicron or not, and sequencing these cases, because you will have your answer there if Omicron is producing severe disease or not.
Of course. We have another question from Vineet Ambart, who's asking, given the surge in the cases in India, what could be the possible peak number of cases and the peak period in India for the 3rd wave? For you, Dr. Mukherjee.
I feel like I'm practicing data astrology these days instead of data science. So it's very hard to project. And I have always resisted, and even more so right now, because the cases are exploding and growing at such a fast rate. And I actually honestly truly believe that you are never going to, the testing is not going to scale up, and whatever you have is actually going to be an approximate. But in terms of infections, so, and you know, the models that we use need a lot of assumptions. And the one key thing that we need to know is that what percentage of vaccinated people and people with past infection are getting reinfected. And that those numbers we are borrowing from other literature, as well as what percentage of severe cases, that also we are borrowing in the literature. So my best guess is that, you know, the infections are going to really skyrocket, and we should not be very nervous or panic driven by that, because this is something that is expected. And what we see is sort of like a tall and skinny peak again, like, you know, because so many people are getting infected. But we do see, if we use the South African data as a model, that we see that 30 to 50% of the number of severities, and that may be again based on a lot of assumptions. So that's reassuring. And it may be very different for Indian data because we have not seen the data from India yet. But I think that you can expect a very high number of cases. And other models also are predicting a peak at the end of January or early February. There are so many unknowns. I hate to do this because I want to practice science. I don't want to do guesswork.
Of course. We have a question coming in from Jilesh Anandkar, who's asking, and this is for you, Dr. Satwik. He's asking, should we take it lightly, Omicron lightly, as it has low hospitalization, but numbers show that it affects medical personnel as well, which will affect the health infrastructure. If you could talk about the health infrastructure a bit as well and our preparedness for dealing with another wave.
Well, we're only started, and we can see severe strain on our health services. I think the real crisis here is going to be a complete collapse of human resources, because we're already finding it difficult to maintain levels of safe staffing in most of our hospitals in Delhi and Mumbai. And in fact, to the extent that many of our doctors who got in, and healthcare workers who got infected early on have now started joining back because of the abbreviated period of isolation that has been offered. But no, I don't think this isn't all that I've said about mildness of the disease isn't to disregard caution, because as I said, we still don't know enough. It's possible that it might play out differently, because immunologically, populations of different countries are disparate. So I think the jury is still out on that. But what is clear is that this is the second fastest spreading virus in the history of humankind, and it's currently undertaking this explosive conflagration in most of our metropolitan areas. So it's entirely possible that you might see a couple of million cases in India every day, and you're going to reach peak testing capacity. In fact, it's already, I think, in Mumbai reaching saturation point. And my point is that this is like a Malthusian crisis, because infections will grow exponentially, but your resources can only be added arithmetically. You cannot suddenly exponentially increase the number of testing kits. So you will have to behave as though and assume that you're infected if you're showing symptoms that experts have pointed out could be COVID-related symptoms. And if you don't have access to an RT-PCR or even a home-based test, you must behave as though you're infected, because as a lot of experts have repeatedly stated, that mild for someone with a good immune response needn't be mild for someone with a poor immune response.
Of course. A final question here for Dr. Mukherjee. Now, a study has estimated that India's cumulative COVID deaths by September 2021 were 6 to 7 times higher than what was reported officially. Do you think this estimate is reasonable? And you've spoken about our response a bit in your previous answers, but how do you think underreporting impacts our response? If you could talk about it a little bit more, from, of course, how the government handles it, but also about how people react to it.
Yeah, so that's a great question. And, initially when we were running our statistical models, the death numbers from India during the second wave just did not add up with the model projections. And at that time, we did not have the excess death data, the empirical data. It was only based on model projections in terms of estimated infections and conjectured infection fatality rates. So, but still, the numbers are orders of magnitude off. And that's when we first spoke about it. But then different groups actually collected data, and journalists played a huge role in getting that data. And also different groups take subnational data. I'm a part of the WHO fatality estimate group, and we have seen subnational data from India, and the story is the same, that there has been a lot of excess deaths during that time period. And the underreporting factor, if you do a meta-analysis, it actually ranges from 4 to 12 of what has been reported, 4 to 12 times. I have to also say that not all of it is directly attributed to COVID. So we have to make that distinction. In the US also, there has been excess death calculations, and only about 72% of that is due to COVID. But we have seen that in developing countries, this fraction of excess deaths, which are attributable to COVID, but indirect, and the other component, which is indirect contribution of COVID, which is due to delay in care, which is due to limited access to transportation. And so all of these actually constitute a large chunk of it as well. So I do think that we have to really understand that that proportion, and we don't have data to pin that down yet, but there is absolutely no doubt that it is at least 4 times more. And the estimates are all over the place, 4 to 12. And the meta-analysis estimate is right on the ballpark. And what does it how does it harm, right? Because we cannot bring people back. Again, I think it's very important to have accurate data to really appreciate the extent of the pandemic. And that could influence people's behavior, that could influence policy allocation in terms of resource allocation, that which countries should get vaccines first or prioritized, right? So, because if we don't know what went on, then we'll always think that there is not a documentation. It is much more milder when it has been much more acute. But then there is also a philosophical perspective respecting people's lives and thinking about the people that we have lost, and there is a quantification of that. In general, I think death reporting systems beyond COVID needs to be improved. It's incredibly hard in rural areas to get a death medically certified. It is reported, but medically certified with the cause of death, I think it's incredibly challenging. But we have to think about creative ways of maybe crowdsourcing data, doing other linkages from which we can obtain this information. And there were many, many creative solutions actually which were proposed during this time, which I think is going to bolster the system of death reporting in India as we move forward. Because there's one good thing about this whole period of crisis, that people came up with gems of ideas and pearls of wisdom which can help us move forward. So as much as I'm critical, the criticism is only going to help us do better things in terms of the data reporting system.
Of course, on this note, we've reached the end of this episode. A big thank you to all our panelists for joining us today. As for our viewers, I hope you found this episode helpful, because I personally did. Do let us know in the comments section and keep supporting us the way you do.